Ever wondered what's truly going on inside your digestive system when something just feels off?
Mhm.
It's a complex, incredibly fascinating world down there, and the signals it sends can range from, little nagging discomfort to urgent screaming alarm bells.
It's absolutely true. The gut is often called our body's second brain for a reason. Its health influences so much more than just how we process food.
Right.
It impacts our energy, our mood, even our long-term well-being. It's all connected.
And today, our mission is to take a deep dive into the stack of sources you provided. We're going to unpack some of the most common, intriguing, and sometimes serious issues that can crop up in your gastrointestinal tract.
Yeah.
Our goal really is to give you those aha moments, help you feel truly well-informed, and understand what to look out for in this vital, often unseen part of your body.
And we'll navigate this journey sort of from the top down, covering everything from your esophagus and stomach through the intestines to the liver, gallbladder.
The whole works.
The whole system, yeah. And even essential screenings that can catch serious issues early. We'll focus on the key symptoms, how they're diagnosed, and most importantly, what it all means for your health.
Okay, let's unpack this starting at the very beginning of the digestive journey. The esophagus. The tube that gets food from point A to point B.
The food pipe.
Yeah, exactly. We often think of it as just a simple conveyor belt, but it's clearly more complex, and when it acts up, it can cause some surprisingly common discomfort.
It definitely is. And one of the most common complaints related to the esophagus is that burning sensation we call heartburn. Often accompanied by regurgitation. These are classic signs of gastroesophageal reflux disease, or GERD.
Right, the dreaded reflux. Our sources suggest for initial treatment, an empiric trial with a proton pump inhibitor, a PPI. What's interesting here is that this step actually serves a dual purpose. It's kind of diagnostic and therapeutic.
That's exactly right. If you have even a partial response, the dose might be doubled, maybe to twice daily. But what's truly crucial to understand is when that initial PPI trial isn't enough. If symptoms persist after, say, 4 to 8 weeks of consistent twice daily PPI therapy,
Right.
or if you have what we call alarm features, well, that's a crystal clear signal to dig deeper.
And those alarm features are truly important for you listening to know about because they're red flags for something potentially more serious.
Absolutely.
If you're over 50 and these symptoms are new, or if you experience difficulty swallowing, which is dysphagia, unintentional weight loss, anemia, vomiting blood, or those black terry stools, those are all urgent signals for an upper endoscopy.
Exactly. For situations where PPIs aren't cutting it, or if those alarm features pop up, a 24-hour pH study can help correlate your symptoms with actual acid exposure and really nail down what's going on.
Now let's talk more about difficulty swallowing, dysphagia, because that can signal various things, and it's more nuanced than people might realize.
Yeah.
There are distinct types, right?
Yeah. Yes, there are. First, there's oropharyngeal dysphagia. That's where you have trouble initiating the swallow itself.
Right at the start.
Yeah. It often comes with embarrassing coughing or choking spells, and sometimes even nasal regurgitation, where food or liquid comes back up through your nose.
Oh, wow.
This type is best assessed with specialized imaging like a modified barium swallow or video fluoroscopy.
So that's the initiation part. And what commonly causes that kind of difficulty? Is it nerves or?
It can be neuromuscular, like from a stroke or Parkinson's disease, affecting the coordination of your swallowing muscles. Or it can be mechanical, like a Zenker's diverticulum.
A Zenker's what now?
It's like a little pouch that forms in your throat where food can get trapped. And that pouch can also cause bad breath. And weirdly enough, you might even find regurgitated food on your pillow in the morning.
Fascinating. Okay, so if the problem isn't at the very start of the swallow, but after you've initiated it, what does that usually point to?
That's esophageal dysphagia. Now, if you only have difficulty with solids,
like bread or meat.
Exactly. It often suggests a mechanical obstruction, like a Schatzky ring, or an esophageal stricture, basically a narrowing in the tube.
Yeah.
But if you have difficulty with both solids and liquids, that points more towards a motility disorder. The muscles of the esophagus just aren't moving food along properly, like in a condition called achalasia.
I remember reading about Schatzky rings, that classic feeling of steak stuck in your throat.
That's a classic description, spot on. It's diagnosed with a barium esophagram, an X-ray study, and often treated with a simple dilation to open up the narrowing, plus some acid suppression.
And then there's eosinophilic esophagitis, or EOE.
Yeah.
I understand this often affects younger males, maybe with a history of asthma or allergies.
That's right.
who still experience intermittent difficulty swallowing despite trying GRD treatment. That's a surprising connection.
It is a surprising connection for many, yeah. On endoscopy, doctors might see these characteristic longitudinal furrows or concentric rings.
Like tree rings.
Kind of, yeah. Sometimes called trachealization. The diagnosis is confirmed by a biopsy looking for specific immune cells called eosinophils. Treatment usually involves corticosteroids, either oral or topical, almost like an inhaler for your esophagus, and trying to avoid specific allergens.
Achalasia sounds like another tricky motility disorder. What are the hallmarks there?
It absolutely is tricky. Patients experience dysphagia to both solids and liquids, difficulty belching, and often regurgitation of undigested food.
Undigested.
Okay. A barium esophagram will often show a characteristic bird's beak narrowing at the lower end of the esophagus because the muscle there, the lower esophageal sphincter, isn't relaxing properly. Manometry, which measures muscle pressure, confirms the diagnosis.
And is there anything else important about achalasia?
Yes, a critical aha moment here is that achalasia, if left unmanaged, significantly increases your risk for squamous cell carcinoma of the esophagus down the line. So management is key.
Wow. Okay. And what about discomfort that's caused purely by medications? Is that common?
It can be. That's pill-induced esophagitis. It's essentially a localized chemical injury, almost like a burn, to the delicate lining of your esophagus.
Ouch.
Often caused by certain medications like some antibiotics, NSAIDs, bisphosphonates for bone health, or even potassium or iron pills, especially if they're taken with minimal water or right before lying down.
So taking pills properly matters.
It really does. This causes that retrosternal burning chest pain and odynophagia pain with swallowing. The good news. The treatment is usually just stopping the offending drug and letting it heal.
Moving on to some very serious esophageal emergencies, our sources highlight Mallory-Weiss tears and esophageal rupture. How do these differ? One sounds much worse.
They differ significantly in severity. A Mallory-Weiss tear is a mucosal tear, sort of a superficial rip, usually near the bottom of the esophagus or top of the stomach.
What causes that?
Typically a sudden, forceful increase in intra-abdominal pressure, like from severe vomiting or retching. It causes upper GI bleeding, but it's usually self-limited, meaning it stops on its own and it's managed with endoscopy.
Okay, so serious, but usually manageable. And esophageal rupture, or Borhave syndrome.
That sounds dire, and it is. It's a true medical emergency, a full-thickness tear right through the wall that needs immediate attention.
What are the signs?
The classic triad is forceful vomiting followed by severe chest pain and subcutaneous emphysema, that's air trapped under the skin, often felt as a crackling sensation.
Crackling, wow.
Yeah. A rapid development of fluid around the lung, a pleural effusion, often on the left side, is another key clue. Diagnosis is confirmed with an esophagram or CT scan. Management often involves surgical repair.
And a critical warning.
Yes, be aware that blindly passing a nasogastric tube in these situations can actually worsen the perforation, especially if it's due to swallowing something corrosive. Extreme caution is needed.
All right, let's descend further into the GI tract and talk about the stomach, specifically decoding general stomach discomfort known as dyspepsia and ulcers. Dyspepsia sounds like a very common, often vague term.
It is. It's sort of a catch-all. Dyspepsia covers a range of symptoms in the upper abdomen discomfort, maybe feeling full right after eating or getting full too quickly, early satiety.
So what's the first step?
Well, the initial practical approach is often to try and eliminate aggravating factors like NSAIDs, ibuprofen, naproxen, and excessive alcohol. See if that helps.
Here's where it gets really interesting and practical for you, our listener. The age-based evaluation for stomach issues. This seems key.
It really is. If you're under 60 and experiencing new dyspepsia symptoms without clear GERD symptoms, you should first be tested for Helicobacter pylori infection.
The H. pylori bug.
Exactly. Usually with a non-invasive test like a urea breath test or a stool antigen test.
Okay, and if that's negative?
Then a trial of a PPI, like we discussed for GERD, is appropriate. However, and this is a key takeaway, if you're 60 or older with new onset dyspepsia.
The approach changes.
Completely. An upper endoscopy is the recommended initial evaluation. The age threshold really shifts the diagnostic pathway because the risk of something more serious, like cancer, increases with age.
And just like with the esophagus, there are clear alarm features for dyspepsia that absolutely require an endoscopy, regardless of age, right?
Absolutely. These include being over 50 with uninvestigated dyspepsia, meaning it hasn't been checked out before anemia, any difficulty or pain with swallowing, dysphagia or odynophagia, vomiting, unexplained weight loss.
Family history.
Yes, a family history of upper GI cancer, or a personal history of certain stomach conditions like peptic ulcer disease, previous gastric surgery, or finding an abdominal mass on examination. These are your body's urgent signals saying, look closer.
So if H. pylori is suspected, how is it diagnosed for sure and then treated?
Diagnosis is either non-invasive with those urea breath or fecal antigen tests we mentioned, or through a biopsy taken during an endoscopy if one is being done anyway.
Okay.
And it's important to note, PPIs can make those non-invasive tests less accurate. They can decrease the sensitivity. So ideally, PPIs should be held for about 2 weeks before testing to get a reliable result.
That's a vital practical detail. And for treatment, what's the standard approach?
Standard triple therapy, that's a PPI plus 2 antibiotics, usually clarithromycin and amoxicillin, for 10-14 days is first line, assuming no penicillin allergy or prior use of that type of antibiotic, a macrolide.
And if that doesn't work, or there's resistance?
If there's high resistance to those antibiotics in the community, or if the initial treatment fails, we move to quadruple therapy, a PPI plus bismuth, like in Pepto-Bismol, and 2 different antibiotics, metronidazole and tetracycline, also for 10 to 14 days.
And checking it's gone is important.
Crucial. Eradication of the bacteria should always be confirmed after treatment because it's so important to get rid of it completely.
H. pylori isn't just about ulcers or discomfort. This is a significant aha moment.
Yeah.
There's a strong, quite sinister link to certain stomach cancers and a type of lymphoma called multimphoma.
Yes, that's right.
Especially in patients from regions where H. pylori is very common, like East Asia or Latin America.
Exactly. This makes biopsies during endoscopy and potentially even repeat endoscopy really important in those cases, almost as a cancer prevention strategy. Catching changes early.
This raises another important point. What about NSAID-related gastrointestinal injury? So many people take over-the-counter pain relievers.
It's incredibly common. For prevention, if you're at high or moderate risk for GI problems and you need to take chronic NSAIDs, things like ibuprofen or naproxen regularly,
What should you do?
the recommendation is often to switch to a different type, a selective KOX2 inhibitor like celecoxib, if appropriate, or to add a daily PPI for protection.
And what about coated aspirin? Does that help the stomach?
Our sources clarify a surprising fact here. Enteric coating on aspirin, designed to protect the stomach, does not actually reduce the risk of this type of GI injury or bleeding, despite what many people think.
That's good to know. So if the damage is already done.
For managing NSAI-induced injury, PPIs are the preferred agent for both treatment and prevention of recurrence. And interestingly, the combination of celecoxib plus a twice-daily PPI has been shown to significantly reduce recurrent ulcer bleeding in those at high risk.
Finally, in our stomach section, let's touch on gastroparesis. It sounds like the stomach is just slow. What are the key symptoms and how is it diagnosed?
Yeah, slow stomach is a good way to think about it. Patients often experience nausea, sometimes vomiting, early satiety, meaning they feel full after only a few bites, bloating, abdominal pain, and sometimes weight loss because they just can't eat enough.
How do you confirm it's gastroparesis?
First, doctors need to rule out any physical blockages or mucosal problems with an upper endoscopy. Make sure nothing's actually obstructing the exit.
Makes sense.
Then, gastric emptying scintigraphy is the key test. This involves eating a meal tagged with a tiny bit of radioactive material and using a scanner to actually measure how fast food moves out of your stomach. It proves there's a delay.
What are the common culprits behind gastroparesis? Why does the stomach slow down?
Common causes include long-standing diabetes, often due to nerve damage, what's called autonomic neuropathy. Certain medications can also do it, like opioids or anticholinergic drugs, or sometimes it happens after surgery due to injury to the vagus nerve, which helps control stomach emptying.
And how is it managed? Is there a quick fix?
Unfortunately, no, it's often about management rather than cure. Dietary changes are key. Frequent, small, low-fat meals with soluble fiber seem to work best. Promotility drugs like metoclopramide can help speed things up.
But side effects?
Yes, metoclopramide is the only FDA-approved drug specifically for this, but it carries a risk of side effects like tardive dyskinesia, which involves involuntary movements. Erythromycin, an antibiotic, can also be used short-term sometimes for its promotility effect. It's often challenging.
All right, let's move into the mid and lower GI, starting with the pancreas. This organ kind of nestled behind your stomach. It often feels a bit temperamental, and when something goes wrong, it can be quite serious and incredibly painful.
It certainly can be. The acute pancreatitis is a prime example of that. What's fascinating, or maybe sobering, is that the vast majority, maybe 80% of cases, are caused by just two main things: gallstones getting stuck and excessive alcohol use.
Just two things causing most cases.
Wow.
So how is it diagnosed? What are the key indicators when someone comes in with that severe pain?
You typically need 2 out of 3 criteria. First, that acute onset of severe upper abdominal pain, often radiating to the back. Second, a sharp elevation in specific blood enzymes, lipase, or amylase, usually at least 3 times the upper limit of normal.
Okay.
And third, characteristic findings on imaging, like CT or ultrasound. A transabdominal ultrasound is usually the first imaging step to look for gallstones, since they're such a common trigger.
And what's the management approach for such an acute and painful condition? It sounds like people are really sick.
They are often very sick. Supportive care is paramount, lots of IV fluids, good pain management. For gallstone pancreatitis, if there's evidence of a blockage in the main bile duct or an infection of the bile ducts, cholangitis.
Then what?
Then early endoscopic retrograde cholangiopancreatography, or ERCP, is indicated to remove the stone or relieve the blockage.
Oh.
And here's a key preventative step. Once the patient recovers from the acute episode, the gallbladder should usually be removed, a cholecystectomy, to prevent it from happening again.
What about complications like infection?
If infected pancreatic tissue, necrotizing pancreatitis, is suspected, antibiotics are used, often potent ones like carbapenems, sometimes guided by a CT scan with a needle aspiration to confirm infection. And importantly, feeding the gut directly with enteral nutrition, like through a feeding tube, is generally preferred over IV nutrition, parenteral nutrition.
That's a lot for acute. What about chronic pancreatitis, the long-haul version?
Right. The hallmark symptom there is chronic, often debilitating abdominal pain, frequently radiating straight through to the back. And historically, chronic alcohol abuse is the most common cause, although other factors like genetics and smoking are increasingly recognized.
So how do you manage that ongoing pain and the other symptoms that come with a long-term condition like this? It must be tough.
It is very tough. Counseling to stop smoking and drinking alcohol is absolutely essential, as these continue to damage the pancreas. For pain, simpler analgesics like acetaminophen or ibuprofen, maybe tramadol, are first line. Sometimes medications that target nerve pain, like pregabalin or low-dose tricyclic antidepressants, can be helpful adjuncts.
And digestion problems.
Yes, because the pancreas isn't making enough digestive enzymes, patients often get steatorrhea that's fatty, oily, difficult to flush stools. Pancreatic enzyme replacement therapy, taking enzyme capsules with meals, is used to manage that.
Now on to pancreatic malignancy. Pancreatic cancer, which is sadly a very aggressive cancer often caught late. What are the big risk factors and symptoms to watch for that might be signals?
Strong risk factors include being over 50, having a family history of pancreatic cancer, certainly cigarette smoking, having chronic pancreatitis itself, obesity, and diabetes. These all increase the risk.
And the symptoms.
The most common symptoms, which unfortunately often appear only when the disease is advanced, are significant unintentional weight loss, persistent abdominal or back pain, and jaundice, that yellowish tint to the skin and eyes, often from the tumor blocking the bile duct.
How is it usually diagnosed if suspected?
A contrast-enhanced CT scan of the abdomen is typically the first major imaging step. It's pretty good at finding tumors. If no mass is obvious on CT, but malignancy is still highly suspected, perhaps based on symptoms or other tests,
Then what?
then endoscopic ultrasound, or EUS, might be performed. That uses an endoscope with an ultrasound probe on the tip to get really close images from inside the stomach or duodenum, right next to the pancreas. It's very sensitive for small tumors and allows for biopsies. Sometimes ERCP is also involved.
Okay, let's shift focus now to the small and large bowel, the intestine.